السلام عليكم. مساكم الله بالخير جميعا. So thanks for the organizing committee and all the sponsors to invite me to this event. So this 25 minutes, I will go over the current therapies of sickle cell disease. We'll go to talk about hydroxyurea role and still, which is from the past up till I think up to the future will be a key line in therapies. The blood transfusion roles in sickle cell disease, the FDA approved medications in sickle cell disease, the bone marrow. I will not talk about the gene therapy. I guess the next lecture will be about gene therapy. So as you see, hydroxyurea from probably from the mid-80s was considered a therapy, and this is based where they observed that patients with sickle cell disease who have high hemoglobin F tend to have less severe disease and better survival. And this is that time that drugs were being used for myeloproliferative neoplasms, and one of the observations that it was increasing hemoglobin F, and this is where it comes to use hydroxyurea in sickle cell disease. And as you see, up till mid-95, where it's approval for adults happened, it's been used until now 23, it's around 20 years, and hydroxyurea is still the key therapy for patients with sickle cell disease. And drugs, as I was mentioning earlier, the main mechanism that it works by increasing hemoglobin F. It has other mechanisms, either improving the RBC hydration, decreasing the blood cells counts, the red cells, the platelets, and the white blood cells, which may play an important role in initiating the process of vaso-occlusion by adhesion to endothelium. This is the MS trial that's in 1995 led to approval of hydroxyurea in adults, patients. And as you see, there is looking at the annual pain crisis around, it's close to 50%, all crises or crises requiring hospitalization. In initial study, there was no survival benefit were observed. So they came as, if you remember earlier at the times, the indication for hydroxyurea was if you have 3 pain crises or 1 episodes of acute chest syndrome, but this is totally changed now with longer follow-up of MSH trial. It's appeared to be showing survival benefits for patients with sickle cell disease as time goes, and especially those who have a robust response with hydroxyurea with persistently high hemoglobin F. Initially also there was questionable, and up to now, about how it really affects the organ damage. Is it protective of organ damage? And all the studies were really non-randomized studies, but most of the evidence came for patients with nephropathy and retinopathy. As you see, in nephropathy prospective studies, around 150 patients, and it seemed decreasing the risk of macroalbuminuria if started earlier for patients. As the same goes for retinopathy, it appears to be a reduction in those who are on hydroxyurea compared to the patients who were not on hydroxyurea regarding of their sickle cell disease genotype. The cancer risk, this was a very limiting point for especially among patients to take the drug for the past 20 years as the potential risk of cancer. But really the potential risk of cancer patient hydroxyurea when we used for MPN, due to the MPN by itself, are really increasing the risk for leukemia. Here, as you see in this last trial, around 17 years follow-up of patients, around 130 patients with sickle cell disease, no cases of myelodysplasia or cancer. So this is a point that we should reassure patients about the absent risk of cancer, and probably they are similar to the general population in cancer development. This is one also of the key things we are asked about it, the influence of sickle cell hydroxyurea and infertility. But just keep in mind that sickle cell disease itself, it will affect the process of spermatogenesis in patients and reduce the sperm count. Also, hydroxyurea, hydroxyurea may be contributing to that. In generally, it might reduce the sperm counts, but they are able to father kids. However, if a couple have been trying to get a baby for a year or more, then this time probably you should do semen analysis and stop hydroxyurea. And it's usually reversible effect on spermatogenesis, the hydroxyurea effect. The second aspect, the role of transfusion. So although you see patients with sickle cell disease, they tend to have lower hemoglobin levels. And this is vary between the genotypes. So usually their baseline hemoglobin between 6 to 9. And we see 6, especially with SS and S beta 0, and probably SC, you see up to 10 hemoglobin levels. But the main thing and the benefit of transfusion is not increasing their total hemoglobin and pushing their hemoglobin from 7 to 10, is basically reducing the viscosity by lowering the hemoglobin S. So there are two types of transfusion. We use TUBAP transfusion. This is kind of rarely being used as in adults. Maybe in pediatric they use it for patients on high TCD, manual partial exchange transfusion, and automated exchange transfusions. This is manual. It's used in peripheral line. It's a slow process, but you don't need a central venous access. This is a kind of standardized protocol, but there are some centers, they will do simultaneous. At the same time, they remove blood, they give fluid, but this is kind of more widely adopted. And this is the apheresis machine. The benefit of apheresis machine, it's rapid process. You can give more blood, you can remove more blood, but eventually you need central venous access to use it. And if you compare both either simple transfusion, manual exchange transfusion, and automated wrist transfusion, there are 2 points to focus on it in these tables. You get the lowest level of hemoglobin S when you go with automated red cell exchange transfusion because you are removing more blood, and the risk of iron overload is way less as well because you are replacing blood with another blood. For acute indication for transfusions, in acute stroke, the main important is really exchange transfusion. In pediatric, there is no role for thrombolytic therapy. In adults, it might be considered, but you should do exchange transfusion before you're giving thrombolytic therapy. And as you see, it really reduced the MCA flow velocity by 20% immediate when you give it to patients. And also patients after that, the risk of stroke recurrence, which is really quite high, up to 70%, reduced significantly. Aplastic crisis, we see it as patients with sickle cell disease, they have shorter lifespan of red cells, up to 21 days. They are more prone to affect with the viral infections, so they may have pure cell aplasia, aplastic crisis more than others. But see, as you see, 70% of them develop immunity, so you might have recurrent infection or parvovirus infection in patients with sickle cell disease. In generally, all the recommendation is to give hemoglobin when it's below 5. Splenic sequestration crisis in pediatric, or hepatic sequestration, which fortunately rare in adults. This is where other indication where patient will be go into hypovolemic shock. However, this is the role of transfusion, and the main thing is to give 1 unit at a time, because whatever blood was pooling in the spleen or in the liver will be back into the circulation at the end of the sequestration. So you don't want to induce hyperviscosity by giving, like example, patient with hemoglobin of 5 or 4, you give them like 4 units or 5 units, you end up like after a few hours or several hours, you see their hemoglobin going to 13 or 14. You would not be surprised because it's just distributed again. Acute chest syndrome, it's the #1 cause of mortality in patients with sickle cell disease, and we can give TUBAP transfusion. Also, there is some data about it, or exchange transfusion. In general, in practice, if patient really severely hypoxic, less than 90 oxygen saturation, we go for exchange transfusion. A patient, for example, coming with hemoglobin of 6 or 7, you might go with TUBAP transfusion if they have evident mild of hypoxemia, but keep in mind, he might progress and you need full exchange transfusion. So just be prepared to insert central venous access and do full exchange. The sickle cell intrahepatic cholestasis, which is kind of the response to transfusion is kind of interesting and unique. So you might have these patients coming into you in ICU. They are hospitalized with acute liver failure, bilirubin shooting in the 200 range, coagulopathic, thrombocytopenic, and usually these patients, due to non-sickle cell disease, they may end up needing liver transplant, but they have really remarkable response to exchange transfusion, and they are really, most of them, the majority will survive just by doing full exchange transfusion. As a prophylactic indication, it's been used as a preoperative transfusion, and if you look at the TABS trial, they looked into low-risk procedure or a medium-risk procedure, and you see most of patients with sickle cell disease, they will undergo orthopedic surgery or abdominal surgeries like cholecystectomy throughout their life. And the point of it is really to target hemoglobin of 10, not much about lowering hemoglobin S in this group of patients. The high stroke risk, those who are coming, either they have prior stroke or they are transferred from pediatric with high TCD, also continuing transfusion, either pediatric they do top-up transfusion, adults we tend to go with exchange transfusion, trying to lower hemoglobin S of 30. However, there are subsequent studies looked into after 4 years or 5 years, you might be relaxing the target level of hemoglobin S to below 50%, and you might manage just doing peripheral partial exchange transfusion in your outpatient day case. I mean, what is important is the number needed to treat to prevent one stroke with full exchange was 1 in 6, which is around 92% reduction of stroke risk. The pulmonary hypertension, it's really just observational data, so it's one of the high morbidity complication of patients with sickle cell disease, and it have to be proved by cardiac cath. As majority of those who have high TRGV, only 6% of them really have actual pulmonary hypertension. So what is really is that what will exchange transfusion do is probably stabilize it and prevent the progression. It's likely to reverse the damage that already happened. This is an inappropriate indication for transfusion, and I emphasize on these multiple things because we should not see really patients with sickle cell disease who have iron overload. However, due to inappropriate indication giving transfusion because they tend to have lower hemoglobin, especially below 7, as for other patients who are non-sickler, when they tend to have lower hemoglobin below 7, they get blood transfusion, and eventually you end up with patients with sickler who have iron overload, and you have to give chelation. And the only way they get iron overload is just simply by transfusion, unlike thalassemia where there are other mechanisms of iron overload. Alloimmunization, it is one of potential issues with frequent transfusions. As you see, the RH group, the E and the C, when the importance. So if you, the phenotyping is really a prerequisite for every new patient who coming into your practice. However, if you want to pick minimal matching, you should go with ABO, RH, and KIL as the minimum requirement for transfusion. Now, with all the new medications with attentions in the last 20 years to find drug therapy, targeted therapy in patients with sickle cell disease, here is the caveat. The sickle cell disease is not one mechanism of the disease. There are pathophysiologies, events, which is quite different from each other, leading to all the spectrum of complication of sickle cell disease. So they trying to look about a drug that targeting the adhesion step, which is the initial step of vasoocclusion. Also, there's a lot of reactive oxygen species, so they tried antioxidant, antiplatelets. Usually platelets are really activated in patients with sickle cell disease in in vitro studies, trying to go anti-sickling and hemoglobin F induction. Also, anticoagulants have been tried, and this is kind of sample of what drugs being used, but unfortunately, majority of drugs, they die in the preclinical phases. And some of those who reach phase 2, or sometimes as we saw recently phase 3, eventually proved not effective. So I will talk about three medications that got FDA approval, US, and this is also Saudi FDA approval. Voxelotor based on HOPE-3 trial. It is when they tried 2 doses, 1500, 900 milligram versus placebo. Their primary endpoint was increase in hemoglobin by more than 1 gram. And also there's other medication that's trying to look at this. I think the rationale that's all either for Voxelotor or other new medication that target increased hemoglobin based on meta-analysis that showed patients who have low hemoglobin, which means brisk hemolysis, tend to have more prevalence of complication like pulmonary hypertension and leg ulcers, nephropathy, and such other complications. So they did not, it wasn't powered enough to detect vaso-occlusive crisis prevention effect. As you see, there was, the drug is bind to the alpha chain of hemoglobin S, and that's the way it really interrupted polymerization of hemoglobin S. So as you see with Voxelotor of 1500 milligram through week 72, and they also up to 96 now weeks, you see there's sustained increase in hemoglobin up to 1 gram, which is main endpoint they were looking for versus placebo. And here you look at around close to 90% of patients really achieve 1 gram increase in hemoglobin, and you see also 3 gram in around 20% of patients hoping on Voxelotor. There is a favor of decreased annual pain crisis, which a trend also were observed. And this is they looked into hemolytic markers, indirect bilirubin, absolute reticulocyte, and LDH, and you see there is remarkable reduction of hemolytic markers. As this one of the medication that looks up high in the pathophysiology of sickle cell disease, not trying to target downstreams mechanisms. Crizanlizumab, which is probably a sad story here. When it came in the SUSTAIN trial, phase 2, it was looking at a B-selectin inhibitor, and it was really looking at this, maybe encouraging the result at that time, decreasing the pain crisis by 45%. FDA approved and Saudi FDA approved at the time. However, sorry. The phase 3 trial showed there is no difference, even when they went with higher dose 7.5 between crizanlizumab and placebo, so it's really off market. The third drug, it's USA FDA approved, it's not Saudi FDA approved yet, is L-glutamine, and it is an antioxidant. This is an oral medications, 2-to-1 randomization, around 48 weeks follow-up. They included patient of age of 5. Voxelotor approved in the kingdom, by the way, from age of 12, but in the USA it's approved from age of 5. And also they were targeting pain crisis in general, and as you see, they did the reanalysis of their data, which show 45% reduction in annual pain crisis and rate of acute chest syndrome. Okay, I just put this slides for, it's not the USA FDA approved, and this is, they are recruiting for phase 3, but I think this is interesting drug. They were looking about mitapivat. Mitapivat had been approved for pyruvate kinase deficiency, USDA approved for it, but now there are studies in both, in sickle cell disease and thalassemia, and the goal of that is really just to increase their hemoglobin, and similar to way to Voxelotor with different mechanism. And it seems that around 46 of patients really achieved their goal of around 1 gram increase in hemoglobin. Now I will move to the last part, which is bone marrow transplant. I mean, it's one of the only cure therapy now. We have gene therapy and other curative options, but bone marrow transplant has been used in children and adults, and in adult physician and adult hematologist. As you see, there are kind of indication we give, we select patients who need bone marrow transplant. Now it has to be match-related siblings, allogenic transplant, but now there is a rising use of haplotransplant as another way. And all this, the data looked into this international survey of result of HLA matched siblings. As you see, the event-free survival and overall survival were both lower with increasing age. And also the overall survival was lower for peripheral blood transplant recipients. So it's really better to be done in pediatric, but in adults it's still a reasonable option to be used. And for every 1 year increase in age, there is around 9% increase in hazard ratio for treatment failure, and also there is 10% increase in hazard ratio for death. The myeloablative has been, I mean, probably it's more in pediatrics, kind of has a lot of toxicity for if they are adults, because when you are growing in adults with sickle cell disease, you tend to have comorbidities, either related to sickle cell disease or unrelated to sickle cell disease, which make patient prone to more toxicity due to myeloablative regimens. Then it comes the non-myeloablative regimens as a potential really alternative for allogenic transplant. So studies have explored multiple conditioning regimens for bone marrow transplant, including alemtuzumab, fludarabine, melphalan, sirolimus, and low-dose radiation. And also treosulfan-based conditioning has been shown to promise in ensuring graft. The use of cyclophosphamide also have been investigated to improve engraftment in patients with severe organ damage undergoing Havalou transplant. But as you know, any patient, any conditioning regimen is influenced by multiple things relating, including patient tolerability and the donor type. But goal of mixed chimerism is really acceptable in patients with sickle cell disease. I'm just sharing our colleagues Riyadh National Guard Hospital, where they did use this regimen, which is alemtuzumab, TBI, and sirolimus, and peripheral blood collection. They discontinued immunosuppression at 1 year when the CDT chimerism more than 50%, around 122 patients. And this is a slide that's showing patients around 122. Eventually, 103 are alive with a stable donor chimerism. Few of the patients really didn't work, and they tend back to receive sickle cell specific therapies. So in summary, hydroxyurea remains an essential drug. It was in the past, it is in the present, and I think it will be in the future for a very long period. And it should be to every patient with sickle cell disease, regardless of their pain crisis events. L-glutamine can be used with or without hydroxyurea for pain crisis prevention. Voxelotor, it's probably in a way, its mechanism is a new disease-modifying therapy. However, we don't have any data about organ damage. I think maybe years from now we might have. I think the ultimate goal will be combination therapy. There's multiple mechanisms of sickle cell disease. We should have multiple drugs at the same time work in these patients. I think this will be also the future for it. And that's it. Thank you very much.